We could probably start.
We can start?
Yeah.
So greetings, everyone. We're waiting a few more minutes to see if more participants will join. So I'm Dennis Falson. I'm from the Global Tuberculosis Program of the World Health Organization here in Geneva, Switzerland. And I am very happy to co-chair this session with Mike. So maybe Mike can introduce himself briefly.
Yeah, thank you very much, Dennis, and hello to everybody. Good morning from New York. I'm Mike Frick, co-director of the TB Project at Treatment Action Group. Very happy to be co-chairing today's webinar. Dennis is going to start us off, and then I'll take over about halfway through the program. But thank you for being with us, and back to you, Dennis.
Thank you, Mike. So with that, I would like to ask Desi Tarleton to give us the introduction to this seminar, which will be focusing about the pediatric formulation of rifapentine, which is a very exciting development in the field of TB preventive treatment, or TPT, for children. So Desi is a program manager at Unitaid. She manages most of the Unitaid investment in TB across prevention, diagnostics, and treatment. She is a health economist with an international organization MBA, and 15 years of experience in managing health and development prospects in low and middle income countries. So Desi will start. You have 5 minutes, Desi, and introduce us to this 90-minute session. Thank you.
Thank you, Dennis, for the introduction. And good morning, good evening, and good afternoon, colleagues and friends. Thank you so much to the IMPAACT4TB Consortium and for WHO and all the partners here for putting this webinar together. As Dennis said, we're here to discuss the progress on new pediatric formulations for rifapentine, and it's just such a pleasure to see how our collective efforts are providing countries and programs with more options to improve TB prevention. For those of you that do not know Unitaid, we were established 17 years ago as a development agency for innovation. We are hosted by WHO. I'm here with Dennis. You can't see me, but we're together. Our strategic mandate was to accelerate equitable access to life-saving, game-changing health technologies, primarily TB, HIV, malaria, co-infections, but more recently, women and children's health and pandemic prevention, preparedness, and response. We also invest in cross-cutting areas such as for strengthening the health system, such as oxygen access, regional manufacturing, and addressing the impact of climate change on health. A major focus of our strategy is equitable access, meaning that we look to accelerate access not just in high-burden countries, but also in populations where access is behind. And regrettably, these populations are often children. What do? We essentially analyze, we discuss with all of you, and we determine what are the barriers preventing people from accessing more effective care sooner, and what solutions remove those barriers. So our investment IMPAACT4TB is a great example, and I love giving it as a great example for how Unitaid operates, where we identified a potential solution that was not available where it was needed. And we worked with most of you here to get, all of you here, to get this solution to the right place. If you remember, a few years ago, 5, 6, 7 years ago now, rifapentine was $70 and only available in 1 or 2 high-income countries. It didn't have critical evidence on how it interacted with dolutegravir, which is in first-line treatment for people living with HIV. And when we decided to invest in this intervention, we knew we had to cross the evidence, formulations, affordability, supply, demand, financing, every single barrier, you name it. And of course, dispersible, easy to use, affordable pediatric formulations were not available. And that's why having the right partners, championing everyone, connecting the dots, and having all of you behind this effort is so critical. and also finding the right tools. The early market access vehicle, which you'll hear a little bit about today, is one of those vehicles. It will be presented as one of the tools that we have in our toolbox to help countries in making decisions of what products fit best in their programs. This vehicle is supported by a great team of experts within and beyond the IMPAACT4TB consortium, and of course WHO, and can provide guidance and tools on technical procurement, implementation, advocacy, and demand creation challenges. That's what everyone is here to support. I'm not going to go into detail on how this tool works. Maka and the team would do that. I'd just like to say, finally, on behalf of Unitaid, a huge thanks to all the partners, Aurum, TAC, CHAI, WHO, GDF, funding partners, industry partners, programs, communities, everybody. They've been instrumental in this effort and ensuring children needs are prioritized. So great to see this coming to fruition, and thank you.
Okay, so thanks very much, Desi. Thanks very much, Desi, for that. And with that, I can pass on to the next speaker, who will be speaking about TPT in children. And the next speaker is my colleague, Avinash Kanchar, who is a medical officer here in our program. He is working mostly on policy development and supporting programmatic management of TB preventive treatment, TB infection prevention and control, and digital technologies for TB. He is a medical doctor with a postgraduate degree in public health. And prior to joining WHO headquarters, he worked at WHO as a field consultant on national TB and HIV programs in India for more than 10 years. He contributed to the development of several WHO documents, latest being the second edition of the WHO guideline on TPT and the handbook on TB. IPC. So with that, I invite Avinash to take on, and you have about 15 minutes. Thanks. And you can share your screen, of course.
Hi, Dennis.
You
please see
can
my
put in
screen.
display mode, right?
Yeah, I'm trying. Yeah. Is it okay?
Yes, you need to remove the speaker notes. Yeah, please.
Okay.
Okay.
Thank you. Thank you very much. And thank you, Desi, for setting the stage. Greetings, colleagues. So I will be providing a brief background to where we are in terms of programmatic implementation of TPT, and also provide some data, and then close by highlighting some of the issues that we face in scaling up preventive treatment in children. So as you are all aware, TPT is part of the NTB strategy, and WHO has always promoted it since 2015, and it actually fits very well into the larger prevention framework, which includes activities like active TB case finding, infection control, but TPT forms has an important place in this. There has been quite a lot of progress over the past few years, particularly last 5 years, which largely driven by TPT implementation among people with HIV. And last couple of years, we are seeing some scale up among contacts who are adults. But if you see this green bar here, we see there was early increase in coverage of TPT among children who are contacts, but now it has stagnated over the past 4 or 5 years, and we don't see much further scale up. And we say this because in 2017, you remember member states committed to large targets for TPT, 30 million individuals to be put on TPT by 2022, which included 4 million children who were contacts. And we were able to achieve just about 50% of this target. More so, you also know in November last year, at the second high-level meeting, we had greater commitments from the member states, and now the targets, the numeric targets that were set, is to achieve 90% coverage of TPT among the eligible populations. And again, this includes about 30 million household contacts, which includes a large chunk of children who are contacts. But there are challenges, and this is an important challenge to reach the household contacts and start TPT among them. So we have this reported by about 68 countries last year to the WHO. And this is cascade of care for household contacts, starting from contacts who are screened for TB, and then who end up on TPT and go on to complete TPT. And we see a large gap there among contacts who the programs report to us, but a tiny proportion of them are started on TPT. Just to remind ourselves, it's important to scale up TPT, and this slide shows us results from a systematic review that we did way back in 2017, and this highlighted the risk of TB among household contacts compared to the general population. And if you see these red blocks here across all the age groups, contacts have about 25 to 30 times more risk compared to the general population to acquire TB. So this is a very important group of people that programs need to target and get over the bottlenecks in coverage. We also know that the TPT regimens, drugs that we now recommend, they work. They reduce the risk of TB between 60 to 90%, and they also save lives, irrespective. I mean, in addition to ART, and this was shown in a famous trial, the Temprano trial. And also these TPT regimens, they offer protection for a long period of time. Most of the regimens that we recommend are safe. Very small proportion of individuals have any adverse events. Most of the adverse events are self-limiting, and they can be managed clinically. And the rifamycin-based regimens that we now recommend, they have a better safety profile, including rifapentine, which we'll be discussing a bit more. And scaling of TPT doesn't really add to the drug resistance in general, and there is no evidence till date, and that should not be a concern in scale up. So I'll now mention some of the recommendations that apply to contacts and particularly children. And this is from the latest guidelines, the TB screening guidelines that WHO issued in 2021, and where TB screening systematic program TB screening is strongly recommended for child contacts of people with TB and children living with HIV, given that they have very high risk of TB and a higher risk of rapid progression once they acquire the infection. The TPT guidelines as well prioritize children under 5. There's a strong recommendations to consider them for TPT, along with contacts who are more than 5 years and individuals who are exposed to drug-resistant TB. And among children who are living with HIV, infants under 12 months who are in contact with the person with TB and who are unlikely to have TB disease should receive TPT. And among the older children, they are who are unlikely to have TB disease following national guidelines should also be considered to be irrespective of contact with TB patients. And in fact, children living with HIV should receive TPT even after completion of a course of TB treatment. So these are the guidelines that stay since 2020. And further in 2021, we had more systematic reviews and updates of the existing systematic reviews on different tools for screening. And I have just taken this for child contacts under 15 and children living with HIV. And you're familiar, the first criteria that we use is symptom screen. And for children, it's cough, fever, weight loss, or lack of weight gain and reduced playfulness. And chest X-ray is now recommended to be used for this screening. And absence of any of the above previously mentioned clinical signs or any abnormality on the chest X-ray should be considered to rule out TB safely, and then TPT can be started. We also have a recommendation from on test for TB infection. We already had recommended TST or IGRA in 2018, but now we have more tests available. There are at least 3 technologies there which are based on and which use the skin test but are based on the IGRA principles, and they are now recommended as well, and some of them are near availability on the GDF catalogs or on the markets. For TPT regimens, there are multiple options in addition to the isoniazid that we had before. So we now have this weekly 3 months rifapentine and isoniazid, 3 HP, as well as daily isoniazid and rifampicin, the 3R HR regimen, which are strongly recommended. And then we also recommended 1 HP and 4 months of daily rifampicin since 2020. We also recommend decentralized delivery of care for TB services in general, and TPT included. And also, in addition to the standard models of care, use of family-centered integrated models of care to deliver these services. And you will notice I have taken these recommendations from different documents, and I have provided QR codes here for you to see them and look at the evidence that was behind. So I just wanted to also mention about this operational handbook that we have along with the TPT guidelines. It provides more complementary details for programmatic implementation, and the usual questions that implementers or providers of TPT have are addressed with latest evidence that we have. And it provides many practical tips around activities like contact tracing. It provides a detailed drug dosage table that I will mention briefly in the next slide. Drug-drug interaction, management of TPT interruptions. These are the questions that you'll find some of the answers in this document. Questions like if people don't miss few doses of rifapentine, what can be the action? And this document will provide different scenarios and provides guidance around that. So as I mentioned, the document also provides this dosing table, and you must have seen this for all the regimens that we have recommended. For 3 HP and levofloxacin in particular, we are anticipating slight changes in the upcoming revision of the TPT guidelines that we are currently doing. You will note for 3 HP, we had suggestion for the dosage above 10 kg. But with the latest document that will be published in July, we'll have recommendations on weight-based drug dosages starting from 3 kg to more than 70 kg. And then this guideline would also have a more explicit recommendation on TPT for contacts of MDR TB patients. So you can find a bit more on the rapid communication that was issued around this. So one key issue that we'll be discussing more in this webinar is around the formulations, and this has been a great challenge for TPT scale up in children. And particularly for children under 2 years, we didn't have appropriate formulation to have a recommendation on. And this is a group that WHO and partners convene called Pediatric Drug Optimization for TB, PADO-TB. And this group looks at all the TB drugs, including the ones for TPT. And in 2019, it had prioritized rifapentine for pediatric use. and by come 2021 September, rifapentine 150 milligrams scored dispersible tablet was prioritized for development, and the developers were called upon to work on this formulation, and we got the first formulation developed and pre-qualified by WHO by November 23, and we'll be discussing more on this formulation today. I also wanted to close with this work that WHO published on the World TB Day, an investment case, and this provides arguments to policymakers and advocates to draw more investments into TB screening and TPT. And I'll just provided two highlights on this slide. The first one shows $1 of investment can yield about $27 of returns on societal costs, for example, in Kenya, and $1 to $39 in South Africa. So this document provides more such insights and advocacy content that you can use and refer to in your discussions with your national counterparts. And also this document we also show a clear increase in prevention impact with both TB screening and TPT scale up at implementation at scale. So I'll stop by acknowledging everyone on this slide and my colleagues at WHO, and I thank you.
Thank you very much, Avinash, for that excellent presentation. I think you touched upon the major issues, and Avinash is working on the current update of the TPT guidelines that are ongoing right now, and which we hope to have out by July with the accompanying handbook. So a lot of work is going into putting the latest evidence and the decisions made by our guideline group. With that, I would like to invite the next speaker, Makaita Gombe, who will speak about the IMPAACT4TB and EMAV opportunity. Makaita, or Maka, is access lead at Aurum Institute, South Africa, and program lead for the IMPAACT4TB, a project driving the uptake of over 4 million patient courses of 3HP globally. With 16 years of experience in health economics, finance, strategy, research, and program management, and designated innovative results-based financing, Maka has a lot of experience on TB case finding, operating across public, private, and NGO sectors. So I see Maka has loaded her slides already. So please, Maka, you have about another, let me see, about another 15 minutes. Yes, please go ahead.
All right, thank you, Dennis. And just to start us off, as was mentioned by Desi earlier, that the IMPAACT4TB project was really here to scale up implementation of TPT, and particularly short course TPT, mainly 3HP, but we've also moved to 1HP. And some of the first objectives of this grant were to generate evidence. So could 3HP be used in people who were also taking DTG-based regimens? So we conducted that study under this project and showed that it was safe and still efficacious for people living with HIV taking DTG-based regimens to also take 3HP. We've just also completed another study, Dolphin 2, that looks at 3HP in people initiating DTG for the first time. And again, that is safe and efficacious and can be done. There was also TBTC study 35 that was looking at the dosing for children under 2. And as was mentioned just now by Avinash, those results are available and will inform the next TPT guideline. We also conducted other studies that looked at service delivery methods. Because this was a novel regimen that was coming in, we previously only had 6 months of INH. We needed to know what service delivery methods could be used. So we also conducted a study called CHIP-TB that looked at community initiation of TPT among child household contacts. And then we also conducted another study, a choice architecture study, that looked at how to improve TPT uptake within ART clinics. All of those results are available and can be found on various platforms. The next thing was then to look at supply side interventions, because at the beginning, there were only a few countries that could access 3HP, mainly high-income countries, because of the price. So we needed to look at price reduction mechanisms, and that was achieved within this project. But in addition, we only had one particular formulation at the time that had a very high pill burden among adults. And so we also wanted to look at development of optimal formulations, so an FDC for adults and this pediatric formulation that's just come onto the market, and to really increase uptake globally. So we've worked with a few different countries and everybody that has been involved in this, the communities, healthcare workers, to really scale up 3HP. We're currently in a costed extension that's looking at the gaps that remained from the initial evidence that was generated. So we have 5 additional studies, Dolphin Kids, that's looking at 3HP in children on DTG-based ART. We also have Dolphin Moms that's looking at both 3HP and 1HP among pregnant women living with HIV, and the safety of dosing the two together. We're also looking at 1 to 3, which is comparing 3HP to 1HP, just to see if there are any preferences from household contacts and people living with HIV. We also have a crush study that is going on, because initially we didn't have a pediatric formulation and children did not have access to the short 12 dose regimen. We're looking at, can children take the crush tablet? And then the last one is really with the introduction of this pediatric formulation now, the feasibility of implementation and all of the specific real world concerns that governments might have, and we're looking to solve these with the study. These are highlights from the project. So as mentioned, the price started off at $72. Within the project, we managed to get the product down to $14.25. And then also with the introduction of other scale-up partners that we've worked with, governments, the US government, GDF, the price has since come down for the adult formulation FDC to $9.99. At the beginning, the capacity that was there for 3HP manufacture was about 180,000 patient courses a year that were being produced. Now we have capacity well over 4 million patient courses, so there shouldn't be any stockouts, at least from the manufacturer's perspective. Now over 10 million patient courses have been procured across various countries that are highlighted on this map. And we've had a lot of community advocacy that was within the project and also spread globally, that worked on guideline updates within countries really, and demand generation to really scale up the product. And a summary of all of the products that are now available. So initially when the project started, there was only the Sanofi 150, but we now have 2 other formulations, the 2 FTCs for adults, a 300 milligram single that can be used for 1 HP for adults, and then the new pediatric formulation that we're talking about now. Just to highlight some of the experiences that we saw within the project over the 12 countries that initially started implementation. We found that there was very little short course TPT used among children, and that was for various reasons. One being the lack of the pediatric formulation. So if you wanted to take up 3HP, either children would have to swallow the tablets whole or crush them to eat with food, which proved a challenge for some caregivers to maneuver and administer in children. And for children living with HIV, they mostly use 6 months of INH for TPT, because currently 3HP is indicated for children on efavirenz-based regimens, but we know that most programs have moved past efavirenz. And for children who are HIV negative, who are household contact, they were mainly using 3HR, which is the daily dose for 3 months. And then for 1 HP children, it's currently contraindicated in children under 13. There are studies that are going on to find out the dosing and prove the safety of that administration. And really one of the things that we saw, so policies and stakeholder collaboration matter in the uptake of newer regimens. If there's ease of registration, then something can be easily taken up in a country. And if the guidelines also support the uptake of a new product, then that usually works better. And so now to talk about the specific formulation. So it is a red pill that was mentioned now, was approved in November 2023, and it comes in a pack of 10 of the blister pack that I show at the bottom there. And then it needs to be taken with the INH, because 3HP is a combination of both the isoniazid and the rifapentine. So the two dispersible INHs that are on the market currently, one from McLeod's and another from Microlabs. Different countries will have different formulations that can also be dispersed in water. So this particular tablet, the pediatric formulation of rifapentine, is functionally scored. So if a child has to take a dose that is not a multiple of 150, the pill can be broken in half, and a child can get 75 milligram increments. It does disperse in water rapidly. It is taste masked. It has a raspberry mint flavor. The INH has a strawberry flavor. The current shelf life of the product is 24 months. And we're looking at exploring bulk packing once the manufacturer has both products, so that we ease some of the supply chain concerns that come with maybe moving two products for one regimen. And currently, because it has been approved, this product can be bought using government or global fund funds, and it's available on the GDF list. And just to go over the pricing, if we compare, so we know that for children, it's usually weight-based dosing. So we just took one average price. For example, if a child needed to take 3 tablets of rifapentine and 2 of INH, the price of the product, so 3HP, which is taken once weekly, so 12 doses for 3 months, would be about $6.53. 3HR would be about $14.18. 4 months of rifampicin would be $15.42. And depending on whether the guidelines say 6 or 9 months of INH, that price could range from $16.20 to $24.30. That's a comparison of the product against other regimens on the market. And so specifically to talk about the early market access vehicle, I've put in a snapshot here, a screenshot of what the expression of interest that we've flighted looks like. And really the eligibility, so who can access this early market access vehicle. And what we've done is, as a project, we've bought some product from the manufacturer that we would like to offer to countries to really catalyze their own scale-up. So countries or governments of eligible countries, UN-related organizations, or any other development institutions are able to access this in collaboration with their ministries of health. They can determine what their need is and then reach out to the team. The details are available in the document, and we can also share it after the webinar. So what we have procured is 3 million tablets from the manufacturer, which works out to about 85,000 patient courses. And the reason that there's not a one-to-one translation is because we know children have different weights and different weight bands have different dosing. And in order to increase access for as many countries as possible, we have about 360,000 tablets per applicant, which is about 10,000 patient courses. And in this way, we're able to then offer more countries the chance to try out this product, see how it will work within their supply chain, etc. And then for procurement and supply chain, so ideally what an interested party would do, they would download the document, fill it in with the country-specific details. So where you're going to implement this, the size of the TB burden, etc., and then send it back to the Aurum Institute. So we have an email address there that's IMPAACT4TB@auruminstitute.org, where you can send the form back. Our supply chain consultant will get back to you, make sure that everything on the form has been filled in correctly. And then we have the GDF ordering form on hand that we'll send back to country teams to fill in. It's the same GDF form that you would have seen for any other TB procurement. Would fill that in where you want the product to be delivered, and who the contact people are, so that we know who to contact when the product is coming, so the country is ready to receive the product. And this opportunity covers the cost of the product and shipping to the warehouse within the country. Any in-country distribution to the specific sites, etc., will need to be borne by the country or any implementing partner within that country. And then we would also offer technical support, training, and tools for country scale-up that are available to help the countries. And then just in terms of reporting, we would ask that in order to be able to share information with other countries that would also like to start scaling this up, just a reporting form that will talk about how many children have been initiated on 3HP, how many completed, how many reported adverse events. And right now, while this is contraindicated in children living with HIV on DTG-based regimens, We're expecting results from the Dolphin Kids study soon that should be able to inform that. So if a country will be using this next year on children living with HIV, if they can also inform us how those children did, and then to also share any qualitative experiences from implementation. So these are some of the tools, as I mentioned, that are available as countries want to scale up. And we have them both for 3HP for adults, 1HP for adults, and then 3HP for children. And that is the link where the tools can be found. So I will stop here. And if there are any questions, we can address them at the end. Thank you.
Thank you very much, Maka. An excellent presentation. So with that, I will hand over to my co-chair, Mike, so that he chairs the rest of the presentations. Thanks.
All right. Thank you very much, Dennis and Maka. We have 3 more presentations left, and then after those, we hope to have a little bit of time for question and answer. For the question and answer, I encourage you to ask questions in the Q&A box. Some of you have been doing that already. We will try to answer some of those live, but also take some for the Q&A session that will follow the presentations. And if you have a question that you want to ask live outside of the Q&A box, you can raise your hand, and I think we have the ability to unmute you when we get to the Q&A portion. So be thinking about what you want to ask about this new pediatric rifapentine product and the early market access vehicle. So our next presentation is about evidence and some service and implementation experience on delivering pediatric TPT. Our presenter is Nicole Salazar-Austin. Dr. Salazar-Austin is at Johns Hopkins University. She is an infectious disease pediatric specialist and really an expert on pediatric TB. She also has a degree in epidemiology from Johns Hopkins School of Public Health and is a noted researcher in this area, focusing on enhancing TB preventive therapy for children and adolescents globally and utilizing biomedical interventions and innovative healthcare delivery models to do so. So without any further ado, Nicole, over to you. And we'll just wait for the presentation mode.
Yep, sorry. I had to unshare to unmute. Sorry. Thanks, Mike. So I'm going to talk about evidence for 3HP. So you guys who've heard me talk before have seen this slide probably many times. We have established efficacy for 3HP in adults living with HIV, in children age 2 to 17 years of age, and efficacy can be assumed for kids under 2. So really high quality evidence there. We also have evidence from the rollout of 3HP in high burden countries, but also from IMPAACT4TB that shows similar and high rates of completion for 3HP to both 3HR and then higher than 6 to 9H. We also have knowledge of similar and low rates of hepatotoxicity and other adverse events with 3HP compared with 3HR and with 6 to 9H. I think what Maka kind of described and what led to the delays in implementing 3HP in children was, one, the presence of a child-friendly formulation. Check, we now have that. Dosing for children under 2 years of age, we should have that in the next few months. And then 3, safety and dosing of 3HP with dolutegravir for children living with HIV, and we should have that in about a year's time. So I want to go through each of the studies and just talk a little bit about where they are and what we know. So TBTC study 35 was a PK safety and tolerability study of dispersible 3HP in children. This was a Sanofi trial formulation and not the Lupin product, but still very useful given all of the bioequivalent studies that have been done comparing each of the products. And this was really essential because this is what's going to provide us with the dosing of this new Lupin child-friendly formulation for children less than 2 years of age. This study has completed enrollment for all age groups, and they're in the process of sharing their data with the WHO, which will inform the TPT handbook and dosing for children under 2 that Avinash and Dennis mentioned is coming out later this year in July. Maka also mentioned the rifapentine crush project. So here we're looking at the relative bioavailability of both the rifapentine INH adult FDC and the rifapentine standalone tablet when taken crushed versus whole. And this was important, you'll remember, because when we crushed the Sanofi tablet, it reduced bioavailability in children by about a third. And so we wanted to understand if this was somehow related to rifapentine itself, or whether whether this would be true in the other in the newer products. And so this study has completed enrollment and results will be available later this year. I do want to stress this is not the ideal formulation. Kids should be getting a child-friendly formulation, but this can be used in a pinch in the case of stockouts or other reasons why children may not be able to access the pediatric-friendly formulation. So just going back, Dolphin Kids is a PK and safety study looking at 3-HP and dolutegravir in children living with HIV. Because children have dolutegravir exposures that are just a little bit lower than that in adults, we couldn't extend the data from the Dolphin study to include children. And we conservatively opened the study looking at twice daily dolutegravir with 3-HP to ensure kids had safe dolutegravir exposures. And then once we understood how a little bit better the drug interaction in pediatrics specifically, we modeled the data to see whether or not we could move forward with evaluating once daily or twice daily dolutegravir. And I'm happy to announce that we had our interim analysis meeting last week, and we will be proceeding with the evaluation of once daily dolutegravir in children living with HIV 2 to 17 years of age. And we've also recently opened the group that will be looking at children less than 2 years of age using data from TBTC study 35 on dosing of 3-HP in that age group. We anticipate the results of this study at the end of Q2 2025, so in a little more than a year's time. So this is just showing all of those studies and the timelines we said. Rifapentine crush in TBTC study 35 with dosing under 2, we should have information on very soon. Dolphin Kids and for children living with HIV, we should have information in about a year. And if you were waiting for information on 1-HP in children, you will need to wait a little bit longer. Because this new formulation has come out, the IMPAACT Network and DAIDS have decided to move forward with evaluating the dispersible tablet and not the rifapentine tablet, which requires some rewriting of the protocol and reapproval. And so that will be delayed by about another, I would say 6 to 9 months, hopefully opening before the end of the year, but possibly early next year. I wanted to take a minute to talk about care delivery models. So we know from lots and lots of data that only about 1 in 3 children who are exposed to drug-sensitive TB in their home receive TPT. And about 2/3 of children are either not identified or don't access facility-based care. And so if we want these new regimens and formulations to make a difference, we need to improve access to TPT. And Avinash described this as well, but these are the pediatric guidelines and what they recommend for models of care, and both decentralized models of care and family-centered integrated models of care are recommended, noting that this is a conditional recommendation, but I think some additional evidence, even since these guidelines came out last year, further support some of this work. And so I wanted to highlight just a few studies that have come out recently that I think are important for programs to consider as they're thinking about how delivery of TPT will happen. The first is a preference study. It was a discrete choice experiment done by Yael Hirsch-Moverman and others at Columbia and ICAP. And here they asked over 300 children, adolescents, and caregivers what they wanted out of a TPT program. And for young children, I think not surprisingly, the number, the size of the pills, the taste, and the side effects were the most important drivers of preference. But for adolescents, the key factors were really waiting times at the clinic and side effects. Dosing frequency and treatment duration were actually less important and really only became relevant if they were linked to fewer clinic visits. So while children is all about acceptability and palatability, acceptability for adolescents is really about convenience, which when you think about the two age groups does make a lot of sense. I wanted to talk a little bit about a couple of different studies that have happened and have evaluated different community-based interventions to reach children. And the first is a PREVENT study, which was a cluster randomized trial to evaluate effectiveness and acceptability of a community-based intervention that looked at enhancing what we're already doing in many settings. And so this includes nurse training and mentorship, health education by community health workers, adherence support, and multidisciplinary team meetings to make sure kids kind of didn't fall through the cracks. And in this study, they did identify more children in the community-based arm. There were high rates of initiation in both arms, but because more children were identified in the community-based arm, the coverage was higher. There was also a 35% increased rate of completion in the community-based group, and overall caregivers found that this intervention was acceptable. A second model was conducted by the CAP-TB study. It was called the CONTACT study, and that was a cluster randomized trial of community-based contact management by a nurse in Cameroon and Uganda. So this was a community-based intervention that had home-based contact tracing, TB screening, TPT initiation, and follow-up. And the vast majority of it was done by a community health worker, but very specifically, the TPT initiation was done by a nurse in the household. And this was for child contacts less than 15 years of age and using the 3HR regimen. They certainly identified a lot more contacts in the home-based arm. More were screened, more were initiated on treatment, more were completed. And in the end, they found a 3 times increased odds of initiating and completing TPT in the home-based versus the facility-based arms. And qualitative and health economics sub-studies found the study to be acceptable, family-centered, and cost-effective. Finally, the last study I'm going to talk about was our study that Maka mentioned earlier, the CHIP-TB study, which was a cluster randomized trial of community-based contact management by community health workers in Ethiopia. Similar to the CONTACT study, we conducted contact tracing, TPT initiation, TB screening, and TPT follow-up. And in this case, all of the steps were conducted by a community health worker. I will say TPT initiation and follow-up was done by a community health worker, and that decision-making was task shared with a facility-based TB focal person. And this was in child contacts less than 15 years of age. We used the 3HP regimen for children 2 to 14 years of age and the 3HR regimen for children under 2. And here it may not be so obvious, but when you compare it to how many children were identified per index case, there were many more children identified per index case in the home-based arm. We also identified, screened, initiated, and completed more TPT in children in the home-based versus the facility-based arm, though this difference was not statistically significant. I still think this is important because the outcomes of the children were similar in the 2 arms, really showing that a community health worker can safely initiate and follow children on TPT and manage and refer AEs appropriately. It was acceptable to families, it was family-centered, and it was cost-saving for the families and low cost to the health system. Finally, in this study, we did do a little bit of qualitative acceptability assessment and regimen preference. And by all of our stakeholder groups, 3HP was preferred over 3RH. And this was really despite the presence of a better tasting dispersible HR FDC. And the reasons for this were a few. So the first was there was thought to be improved adherence with weekly dosing. The weekly dosing allowed HP to be given on the weekends to avoid dosing on a school day. So if there were adverse events, they would not happen and affect the child's school day. It was scheduled on the sort of non-religious day of the weekend, which helped people remember, although a minority of caregivers were concerned that they could forget a weekly dose of a medication, though we didn't find this to be the case in the study itself. Both HP and HR were well tolerated. The providers and community health workers noted that vomiting was possible with both the HP and the HR regimen in young children. And then both regimens had some challenges with acceptability and palatability. Dissolving the HR tablet was time-consuming and needed to occur daily, versus the HP regimen, where the main complaint was the increased pill burden. And this was managed by only giving the dose on a weekly basis, and then also potentially separating the doses of H and P in time and allowing the child 30 or 60 minutes to kind of recover from one before giving the other if that were an issue. And so thought I would highlight that to help as programs make decisions about regimens. And that's it from me, Mike.
Thank you very much. That was a great overview of clinical studies, which are filling in data gaps on using 3-HP and eventually 1-HP in children of all ages, including kids with HIV, on newer ARVs like dolutegravir. And I think a very clear message coming out from the cluster randomized studies that you summarized about just the acceptability of home-based, community-based care. We don't need to be doing this in facilities only. So thank you very much, and encourage people to put any questions for Nicole into the Q&A. Our next presenter is Julie Swatala from Aurum Institute. Dr. Swatala is an infectious disease pediatrician working predominantly in TB, and she's currently the pediatric TB technical specialist at Aurum Institute. And she's practiced in a variety of clinical settings. She ran a pediatric unit of a TB hospital in South Africa for 5 years and has done multiple missions with MSF. And Julie will be doing a demonstration actually of this new pediatric rifapentine product from Lupin, which will include a video of how this can be administered. So Julie, we'll turn things over to you in the demo. Thanks.
Thanks so much, Mike. Welcome, everybody. And I'm very happy I've got the fun section to discuss. Those of you who've given children medication before realize that they don't care about what the studies say, they don't care about the access, they care about getting pills into their mouths that taste good, and that's easy for the family. So while, as we've mentioned, for the reasons mentioned already, this isn't an FTC, so we still have these as two separate medications, but the fact that both tablets are now available as easily dispersible, pleasant tasting medications really goes a very long way in encouraging caregivers specifically to give healthy children medication, which is obviously one of the main barriers in TPT treatment, is we're getting people to give healthy kids medicine that they don't like. So I don't know how good strawberry and raspberry and mint will taste together, but I'm sure most children will find that relatively acceptable. So unfortunately, the new weight banding, even with the changes that we're expecting with the new guidance from the WHO, all of the doses are going to be half or full tablets, which makes life a lot easier than what we've sometimes had to do with adult formulations of crushing a tablet and giving 2/3 of that tablet, which becomes a bit laborious and difficult for families. So this is going to be much easier for families to calculate the correct dose and also much easier to prepare. As we've mentioned, the recommended doses might change based on the new WHO handbook, which is coming out soon, and those doses will be guided by the evidence that's already been mentioned. So how to prepare the medication? Firstly, once the correct number of tablets of each type has been selected, these can either be mixed together in some clean drinking water. And we've guided to say that the amount of water is not as important as getting something that's going to be feasible for this family. So it can be quite a thick mixture, but if you mix all of the tablets together, and that might mean that you need to add more than 30 mils of water, and the child might need a couple of sips or syringe sweeps to get all of that down. But families are encouraged to see what works best for them. We don't want an overwhelming amount of liquid for the child to drink, but we also want an amount that's easy to swallow. So while these are dispersible tablets, there will still be a little bit of sedimentation. So the water can be mixed either in a small cup or any utensil that the family finds easy. And once the medication is given to the child, either they can drink it or it can be given to them with a syringe. And it's very important just to add a little bit of extra water at the end to sort of swirl it around and make sure that the child gets the entire dose. They are dispersible tablets, but they do take a while to mix correctly and mix thoroughly. So it is important to make sure that they are properly mixed. but then to try and give the medication as soon as possible after the complete dissolution of the tablets. In certain settings, the dispersible iron H might not be available. And in those cases, the equivalent dose of the currently available 100 milligram or 300 milligram tablets can be used. Those are usually quite easy to crush, but obviously then they're going to have a little bit more of a sediment than the rifapentine would have. So it's just really important there to make sure that the child is able to consume the full amount. And as for adults, this process only needs to be done once a week. As Nicole's mentioned, that's usually preferable for families. And I think that also makes it easy when you have multiple family members on TPT, that everybody gets their dose on the same day. And it's not different regimens for different people. So these medications are generally very well tolerated. However, it is important when prescribing to caregivers to let them know that firstly, TPT is not perfect. There will be a certain number of children who do develop TB despite being on TPT. And it's also important to let them know which adverse events we would be looking for in those children, and discussing a treatment plan for how to access healthcare if either TB disease is suspected or adverse events. And then I'm going to show you our beautiful video.
Have you ever heard of something called TB? It's a germ that can make us feel sick. Sometimes if someone you're close to has TB, it could spread to you. You might not develop TB disease though, and there is a special way to help you stay healthy and strong. It's called 3HP. Before we start, there are some important things the healthcare worker will need to know to make sure the medicine is just right for your child. Firstly, your child's weight will be determined by the healthcare worker. This is an important step, as the healthcare worker will determine how many tablets your child needs based on their weight. For example, if your child weighs between 10 to 14.9 kgs, their dosage would be 2 white pills and 2 red pills. The white pills are called isoniazid, that has a strawberry taste. The red pills are called rifapentine and has a raspberry mint flavor. Once you're certain of the correct dosage, place your medication in a cup of clean and safe drinking water. The amount of water depends on the number of tablets. Give the cup a good stir. Add enough water and keep stirring to make sure the medication is mixed in well. The child will need to consume all the mixture. You may need to give your child a few sips or shots to complete all the mixture in the cup. If a syringe is available, you can use it to give the child the mixture. A syringe is mainly used for very young children. There will always be some of the dispersed tablet left over in the cup. It's important to add some water to the cup and mix it in with the remainder of the medication. Give the remaining mixture to your child directly from the cup. Or, if available, use a syringe. To ensure the health of your child, make sure to follow these steps once a week on the same day for 12 weeks. Let's do a quick recap of these simple and easy steps. 1. A healthcare worker will check your child's weight. 2. Determine how much dosage is required. 3. Give your child the number of tablets as instructed by the healthcare worker. 4. Give your child the mixture either in a cup or syringe. 5. Add more water to the cup to mix in the remaining mixture left over in the cup. 6. Give your child the leftover mixture from the cup or a syringe. It is as easy as that. Remember to follow these steps carefully to protect your child from getting TB. Stop TB before it starts. Prevent and protect. The medication is very well tolerated and effective. If your child is unwell in any way, contact your nearest healthcare worker or clinic.
All right. Any final word on administration, Julie? You're on mute.
Sorry about that. I think the final word would really just be that you've got to do what works for the child. So different children are going to like different, some kids might like the treatments in the afternoon, some might like it at night. As Nicole mentioned, some might prefer to have the isoniazid given separately to the rifapentine. So be guided by the patient. And I think having medication down a throat is more important than having it given absolutely perfectly.
Don't let perfect be the enemy of good enough in using this new product. It's a great message. Our final speaker is Tendai Westerhoff. We saved the last word for community, and I think that's appropriate because one of the hallmarks of the IMPAACT4TB project was the incorporation of community advocacy in TPT promotion, demand creation, teaching households affected by TB about 3HP and these newer options. And Tendai is one of the community partners under the IMPAACT4TB project. She is the founder and national director of the Pan-African Positive Women's Coalition Zimbabwe, where she leads efforts to address the unique needs of women living with HIV in Zimbabwe. And she has a background in advocacy, is known as a fierce advocate for the rights of women and girls, fighting stigma and advocating for gender equality. And as I said, Tendai and Papwick Zim are one of the IMPAACT4TB community partners who have been doing great work building demand for these products in communities. So Tendai, over to you on the community perspective on this new pediatric rifapentine product and the need for TB prevention in kids. Thanks.
Thank you very much, Mike, and greetings to everyone. I'll talk from a civil society perspective. I hope all can hear me clearly. As civil society communities, we congratulate everyone and herald the introduction of the world's first child-friendly formulation of rifapentine as an essential innovation to save children from TB. As community and civil society leaders, we have worked determinedly to prevent TB in our communities. A quick look at the pediatric TB in Zimbabwe. While children represent around 15% of reported TB cases in the country, Zimbabwe reports only less than half of the cases, that is 6%. Diagnosing TB in children has always been difficult. Protecting them from getting TB is the best solution. When a child is exposed to TB bacteria, they are at a higher risk of progressing to TB disease than adults. It is therefore critical to prioritize them when it comes to TB preventive therapy. We need to embrace child-friendly medicines for preventing TB in children, such as rifapentine, which will ease administration for both the caregiver and the child and improve the health of the community as a whole. The current challenges in pediatric TPT. The current TPT require long durations and frequent doses that are challenging for children, especially those who struggle to swallow. And to swallow the pills. Common issues include the beta test of the medications and the lack of child-friendly formulations, leading to poor adherence. This can result in treatment failure, relapse, and the development of drug-resistant TB strains. There is an urgent need for better solutions to improve treatment effectiveness in children, like this new dispersible flavored formulations, like what the previous speakers have alluded. They gave a very good description of it, and it makes it very palatable for children. We must not leave any child behind and not forget children in key populations, children who have been missed and children who fall out of care. There is need to specific community-led interventions that reach them. These can include establishing adherence clubs, find, test, and treat for TB. As community, we need to find out that if interventions are reaching few workers living with HIV or TB, how are they missing their children? So at initiation of the cohort, it's important to check if they have children and if the children have been linked to care. Another group is adolescents and teen mothers living with HIV. These may shy away from care due to various reasons. There is need to foster an environment to suit their needs and ensure that their children have access to short course TPT 3HP. We do have community. Why are community partners important when it comes to ending TB in children? We need to increase appetite amongst mothers so that we have pediatric formulations for children. HIV positive mothers who get TB give birth, and the child also gets TB, and it becomes a blame game on the mother. The community has a critical role to play in supporting TB prevention efforts by promoting knowledge through treatment literacy. TPT treatment literacy sessions, both at facility and community levels. There is still evidence of misinformation and misconceptions surrounding TPT among community members. Therefore, communities are critical in raising awareness about this dispersible flavored rifapentine and encouraging its uptake among children and caregivers. Community dialogues with opinion and influential leaders can help to address these issues, including the distribution of IEC material on TPT. We need to empower and get communities to do demand creation for 3HP formulations for children to address issues of stigma and discrimination attached to TB, as it is a major obstacle to seeking TB services by persons with TB and completing their TB treatment. Some even give wrong information to avoid tracking and follow-up. There is need for continuous counseling to people with TB and those caring for children with TB on possible side effects and how to deal with them. Extension of DSD models to clients on TPT reduces the facility workload for the nurses and to further strengthen the utilization of the DSD models in clients on TPT. In conclusion, in order for pediatric formulation to take shape and to be scaled up at country level, the issue of price must be looked into so that the formulation is both readily available, affordable, and accessible to all children in need of it. We encourage collaborations between community organizations, healthcare providers, and the government to ensure widespread access to this new treatment option. We call upon our governments to move quickly to procure this life-saving product without further delay. I thank you.
Thank you very much, Tendai. I think that was a great way to go into a general discussion of this topic. And just want to thank you again for leading so much of the community work behind this project. So we've had a lot of questions put into the Q&A. To my mind, they sort of fall into 2 or 3 major categories. We have some questions about this new pediatric rifapentine product itself. And then we have a lot of questions just about TB preventive treatment. Some of those are specific to TPT for kids and some are more general. So I think let's start with the questions that are about the product, because the main focus of today's webinar is this new pediatric formulation and the opportunity to procure it through the early market access vehicle. So Julie, I'm going to ask you to respond to a couple of questions. Some you've answered already, but I think it'd be good just to hear you talk through them live in front of everybody. We have questions about, do the tablets have to be dispersed? Or could this new tablet be chewed or swallowed whole? So that's one. And then we have some questions about the dispersing of the tablet. Can the rifapentine dispersible tablet be dispersed in the same cup as the dispersible INH, or do you need to do that separately? And just how much water do you actually need to disperse them, let's say, if you put them together? So maybe if you can start just by taking some of those sort of technical questions on the new product.
Sure. So obviously this is a dispersible formulation, so it's aimed at children who can't swallow whole tablets, but we actually had this discussion earlier today that sometimes you need a transition. So some children might not like having the dispersible tablets and they want to try and take half a tablet at a time as a whole tablet or in a little bit of food. That is usually going to be acceptable. I don't think that that's been studied as such. We haven't looked at these tablets and what the bioavailability is when they are swallowed, but logic does imply that if it's bioavailable once it's dispersed, it's probably just as bioavailable if swallowed either in wholes or in halves. So I would say without much evidence that I think that would be absolutely fine. Then the second question about how to mix the medications. I think you have to see what works for each family. The bigger the child, the more tablets they're going to need. And that means that if we had to put that in one amount of fluid, it would be very, very thick fluid. So I think there are a few different ways that you could do this. You could either say we want to mix one tablet in 10 mils and just give a series of 10 mils with one tablet properly dispersed, but that might be a little bit time consuming. Some children might prefer to have a thicker but lower volume amount. So maybe we'd usually guess about 10 mils per tablet. Some children might prefer to take the INH separately, particularly if we don't use the dispersible INH. They might like to take the INH tablets as tablets or half tablets, have the rifapentine as a mix. So I think usually we're looking at about 10 mils of fluid per tablet, but we've deliberately left that a little bit open for the family. We also recognize that many caregivers are not necessarily literate, and adding a number just adds a burden. So it's, as long as it's clean, safe water, that should be absolutely fine. And one of the questions that came through on the chat, which we hadn't mentioned, was pyridoxine. So all of the TPT options, whether it's 3RH, INH, or 3HP, because we're giving INH, we do need to give pyridoxine with that. And that's usually a very small tablet. So most children can swallow that, even small babies, but that can also be crushed and put in with the mixture as well. Thank you very much for whoever raised that question. That was an omission on our side.
Yeah, the pyridoxine came from Keto. He's also a community partner. And one thing that all of our IMPAACT4TB community partners have experienced in doing demand creation around 3HP is just that having the pyridoxine really does increase the acceptability and tolerability of TPT for people who are working with our community partners. So glad that we could address that. Nicole, anything to add on the administration of the product questions? And then there's one also that I'll have you address about whether the 3HP fixed dose combination tablet, which is really dosed, for the adult course, could be used for children if crushed. You addressed that a little bit, but if you want to say anything else about crushing adult products, if this pediatric one isn't available.
Yeah, thanks, Mike. I don't have anything to add to Julie's excellent description. I think it's perfect, and I agree with what she said fully. For the crushing product, so I think we're waiting for this rifapentine crush study before we say that you can crush the fixed dose combination and give it to kids. The data for that, the enrollment is complete. They're sending the samples to UCT in the very near future, and we should have data in August. So it won't be long before we have that information, but we don't quite have it now for me to say that it's okay to do that. I know several countries are already doing that, but we don't yet have the data to support a recommendation.
Great. And can you just, we just got a question about a topic you talked about. This is from Mona Balani about children living with HIV who are contacts of TB affected parents or caretakers. Can you just quickly review sort of the state of play, state of evidence for 3HP for these children?
Yeah. So the vast majority of people who come through contact tracing in high burden settings are not living with HIV, from my experience in my studies and in our implementation studies, but there will be a few always. And then there's a recommendation just for children living with HIV in high burden settings to receive TPT. And unfortunately, until the results of Dolphin Kids come out, we're kind of a little bit stuck with what we already had. And so that would be 6 months of isoniazid without a dose adjustment. Potentially, you could do twice daily with 3RH, but there are a lot of complications and it's not in a lot of guidelines. So I don't know that that's recommended in many settings. And otherwise, for 3HP and dolutegravir, we're going to need to wait for the Dolphin Kids study to be completed, and that should be in Q2 of 2025, so about a year from now.
Great, thank you. I'm going to turn to our WHO colleagues now, Dennis and Avinash and Sabine, any of you who want to reply. So a question that's been asked a few times and that you've answered, but I think it'd be worth just addressing this live, because this also is the most frequently asked question when we do community work, is can you take TPT more than once? Do you need to take it more than once? What are the circumstances under which you would take it more than once? Can you just talk through this whole question about re-exposure, the frequency of TPT taking, and answer this for us, because this has come up a lot.
Maybe Avinash can take this question.
Yeah, so what the position we have at WHO is we don't have a recommendation for a blanket repeat course of TPT for everyone received it once. But we do say if there is a re-exposure which is confirmed, for example, in a TB patient in a family, bacteriologically confirmed, it should be a case-by-case decision to start TPT. And we do encourage TPT in such cases, but not as a blanket for the national programs to consider for everyone.
So each new TB exposure is an opportunity to do an assessment, to screen, and to consider whether another course of TPT may be appropriate based on sort of the information at hand. Okay.
Yes.
Could you answer the question in the chat, which was about a clarification around the updated WHO guidelines to TPT that are expected this July, and around the data on the use of rifapentine in children ages 0 to 2. And that's the data that Nicole talked about as coming from a study called TBTC Study 35, which was co-funded by Unitaid. If you want to just address whether the new WHO guidelines will tackle that data gap.
Yeah, we have reviewed these data with a technical advisory group on the dosing of TB medicines. They are still provisional data, so they are not yet fully published, and they are looking at the PK and the safety. There's no need for efficacy data in this group, of course, because the benefits of the treatment can be assumed to the level of children under 2 down to the 3 kilogram weight band. So there will be new guidance on this, and they will feature in the drug dosage tables that will be in the accompanying handbook in July that will come with the guideline.
Fantastic. Maka, I'm going to turn to you now to talk about the early market access vehicle. We received a lot of questions ahead of the webinar about how exactly this will work. And we had questions around country eligibility, price. I think it might be worth clarifying countries that apply to receive the pediatric product through the vehicle. Do they need to pay anything? And what are they on the hook for? If you could just sort of run through the eligibility and cost details again, and let people know how they can apply. Thanks.
All right, thanks. So the form has a list of countries at the end of it. It's about 134 countries that are eligible to apply for this. I can't go through all of them now, but it's most low and middle income countries, with some upper middle income countries as well. So ideally, you would download the form from the website. We can send the link, fill that in to apply for the product. It really asks fundamental questions about the TB program, do you already have INH dispersible, for example, because this early market access vehicle is mainly for the rifapentine component. So countries would need to have the dispersible INH. If that is not the case, you can also indicate on the form, for example, if there's a special consideration that can be made, but for now it is only for the rifapentine. And the applicant would specify how many patient courses or how many tablets they would like to get through this early market access vehicle. As I mentioned, there is a cap of about 36,000 tablets that each country can get. And this is really to expand access across more than just one country. And to also then ensure that, we already have an interest in doing TPT among children. And these are the plans we already have. And this is the gap that this will fill. And it's really meant to enable countries to get experience with the product to be able to scale it up. So once the form has been filled in, send it back to us. There is an email address on the form itself, IMPAACT4TB@auruminstitute.org. Send the form back to us. We'll look at it for completeness, and then we'll send back a form for the ordering process, should everything be in order. And on that form, it's a standard GDF form, similar to what they've seen before for other TB medicines. And that will really be the kickstart of the ordering process for the approved volumes. And then they'll send that form back to us, and then we'll apply through GDF. And that form would really have details such as where this is to be delivered, logistical questions that would need to be sent back to us, and then we'll place the order through GDF. We will pay for the product, and we'll also pay for shipping to the country warehouse, central warehouse. And then from there, the country and the implementing partners or whomever would take it over from there. So the costs to the country would start from getting from the warehouse to the sites. Any training of healthcare workers that they need to do would be part of the country purview. And we assume that there are other TPT programs anyway happening in the country. And this is really providing product to be able to help improve TPT processes. So yeah, I hope that's clear on what we are covering versus what the country needs to cover on their own.
And maybe one basic but essential question, is there a deadline for submitting this interest, or is it first come, first serve? How does it work?
So we have there on their dates until November 2024 is when countries can order. But I do have to say that we do have a finite amount, only the 3 million pills. So if other countries have already ordered and had their orders approved ahead of time, and by November we have nothing left, or we have 5 left, that will be it. There is no additional investment outside of the 3 million patient courses. So I guess first come, first serve, or November 2024, whichever comes first.
So early interest is important, and don't wait if you're an NTP manager and interested in applying. I'm going to give the last question to Tendai. We had a couple of questions in the chat from Samuel Chirwa and Michael Makaria about what are some of the demand creation activities for TPT that are being conducted or planned. I don't know, Tendai, do you want to just talk a little bit maybe about some of the demand creation work for this pediatric product that you see as important?
Yes, thank you so much, Mike, for that question. As you are aware, we are implementing in Sanyati district in Mashonaland, West Province of Zimbabwe. And already we have got things going on the ground. We have trained community healthcare workers, a refresher on TPT. And even during that training, we realized that several of them really did not have sufficient knowledge around TPT and how it affects children, how they must administer the treatment, etc., etc. So that refresher course was very, very important. And also the village health workers, we also trained women living with HIV, because these are the people who are responsible for going to do door-to-door campaigns and tracking in families to ensure that they look out for these children who could be hidden, and that the children are brought into care. And also we are developing IEC material with updated information around TPT and its benefits. And we'll be giving this out to the communities. And we'll be engaging in community dialogues in rural Sanyati, in Kadoma area, at selected places, because, in Mashonaland West Province, it's rated 5th in the country as far as the the TB burden is concerned. So we do have a lot of activities that are going on. And on our part, as the Pan-African Positive Women's Coalition Zimbabwe, we are documenting these processes. We continue to hold virtual meetings and dialogues with women living with HIV across the country, documenting and packaging them in our e-newsletter called the Dandaro Forum. I'm sure some people have seen it. So I would like to stop here, but a lot is happening on the ground, and we are excited with the work. We are also learning. New information is coming, and we are giving it out, and we are so happy that even the healthcare facilities are collaborating well with us, including the National AIDS Council itself and the Ministry of Health and Childcare. They are part of this. We are working on this as partners and collaborating well. Thank you.
Perfect. Yeah, I think these community healthcare worker program collaborations are essential for moving the needle on this. We are running to the end of our time. I'm going to give the final word back to WHO. I'll just note there are a couple of questions that came in that we weren't able to answer. We'll take note of those, especially this one about storage and distribution precautions and some of the other ones that I think are probably addressed in the information on the early market access vehicle that we'll make available, but we'll make sure that all of that is covered if we didn't get a chance to talk about it live here. So Dennis and WHO team, I'll turn things back to you to close the webinar. Thank you.
Yeah, thank you very much. It's been a really excellent session, and it was a real pleasure to also to read the questions and having a chance as well to reply to them, because it always gives us the opportunity to understand what are the frequently asked questions, what are the areas of concern, right? To understand how better to develop our implementation guidance. So with that, we will conclude this session. I think it's really been very interesting, very informative. We had a very broad array of actors here on the TBT. People who are, you know, in the science, people who are really on the ground implementing, and very importantly, the community as well. This is a really important field, right? I think demand creation is the byword in the TPT, because without that, unfortunately, it will slip off from the radar screen of many of these busy managers, right? They need to be aware. And I think this new development with the dispersible rifampicin for kids is hugely important, right? Because it will make the experience of TPT more acceptable for people who need to take it. I think, again, contact investigation has been is a cornerstone for public health, right? We've seen the importance of it during COVID, and that maybe has given us a bit more refreshed sort of drive to use it for TB, and for with TB also to look at other public health important needs in the community. I think models of care that are person-centered, you know, that are decentralized, that can be implemented within a household, within a family, are very, very important to maximize the completion of TPT. I think the UNHLM, the new UN high-level meeting targets inspire us to reach more ambitious targets and provide TPT to all the people who need it. Of course, we should not forget as well other at-risk populations, right? From not just the contacts, but also children with HIV and their relatives. These are important groups that are under-reached. People living in urban informal settlements, like in slums. We have picked these up in the investment case that Avinash has mentioned in his presentation, which is, I think, a very useful data-driven sort of advocacy tool that you can use to motivate governments and to motivate policymakers within state and within other sectors to give due prominence to prevention of TB, screening, TPT, and the related areas of infection prevention and control. We've spoken a little bit about our forthcoming guidelines, so I hope that these will help you by giving you a better evidence base, right, and more updated sort of information. We mentioned mostly about how it affects 3HP in the under 2 today, but there's There's also an important new recommendation on MDR-TB TPT with 6 months of levofloxacin. So this is another important, I think, milestone in TPT, and can address the many questions we've also had before about the efficacy of TPT when exposed to drug-resistant tuberculosis strains. Okay, so with that, I will once more like to thank IMPAACT4TB for convening us today, and also for the many partners who managed to make it for over this 1.5 hours. And thank you again for remaining so numerous up till the very end of this webinar. Bye.